Welcome back, everyone. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Today, we're diving into a really energetic masterclass. We're going straight to the absolute heart of inpatient reimbursement and clinical documentation. Let's get right to it. I want you to think about this for a second. How does one single vague word in a medical chart end up costing a hospital literally millions of dollars in lost revenue? Well, it happens every single day. When a provider just writes a generic symptom like chest pain on a discharge summary, instead of the actual confirmed diagnosis, like, say, acute myocardial infarction, it completely throws off the DRG assignment. And that means massive revenue loss and some seriously scary compliance risks. So today, we're going to fix that. Okay, here's our game plan for today's explainer. We'll start with Welcome to IPDRG Mastery, move into Inside the MSDRG Architecture, cover the crucial POA indicator, then look at CDI queries and compliance, real-world coding scenarios, and finally, denial prevention and wrap-up. We're taking a journey right from the core mechanics of the grouper all the way to real-world clinical documentation integrity. All right, Part 1, Welcome to IPDRG Mastery. Let's jump in by getting a handle on the foundational mechanics of the Inpatient Prospective Payment System, or IPPS. So everything starts right here with the principal diagnosis, or the PDX. This is the condition established after study to be chiefly responsible for admitting the patient to the hospital. The absolutely crucial thing to remember here is that this is drastically different from just the primary symptom a patient has when they walk through the door. Let's say a patient comes in complaining of severe shortness of breath, right? But testing reveals they actually have acute respiratory failure. Well, that respiratory failure is your PDX. This one single code dictates the major diagnostic category and really sets the baseline for the entire hospital payment. You get this wrong, and the entire claim is just fundamentally wrong. Moving on to Part 2, Inside the MSDRG Architecture. Now we're going to look under the hood and see exactly how this logic engine actually partitions and weighs a patient's chart. As you can see, the system basically creates 3 distinct tiers for almost every MSDRG, and this is all based on severity adjustments, the CC and MCC logic. You've got the base level with no CC or MCC, the middle tier with a complication or comorbidity, and then that highest tier with a major complication or comorbidity. Adding just one MCC, something like acute respiratory failure, septic shock, or DKA, moves a case right up to the highest payment tier. Why? Because it proves the patient required significantly more clinical resources. It proves that high severity of illness. Let's hit Part 3, the crucial POA indicator. Present on admission might just be a tiny little letter flag, but it carries massive financial and quality consequences. Take a really close look at these flags. A yes obviously means yes, the condition was present right at the time of admission. This validates that it's a pre-existing condition, allowing it to fully impact the DRG weight. But an N? That is dangerous. It means the condition was not present on admission, effectively flagging it as a hospital-acquired condition, or HAC. Say a patient falls out of bed and gets a concussion, or they get a catheter-associated UTI. That N means Medicare will very often just flat-out refuse to pay for the increased cost of care. So how does the software actually process all of this? Here's the step-by-step logic. First, it takes all your ICD-10 codes, the principal and secondary diagnoses. Second, it runs those secondary codes through that CC/MCC logic tier we just talked about. Third, it strictly verifies the POA flags, just to make sure no hospital-acquired conditions are illegally boosting the payment. And finally, it spits out the final MSDRG and the relative weight. That weight then multiplies against the hospital's base rate to give you your final dollar amount. Let's look at a really concrete example of this in action. Check out the bottom row here, acute deep vein thrombosis. Now, normally, a DVT is a very powerful MCC that drives your payment straight into the highest tier. But look at the POA flag. It's an N. Imagine the patient developed this DVT 2 days after they were admitted for sepsis. Because it wasn't present on admission, CMS absolutely will not increase your payment, even though it's a major complication. And honestly, the hospital might even get hit with a quality review penalty on top of it. Which brings us to Part 4, CDI queries and compliance. The software can only group what's actually written down. So what happens when the provider's notes are just a mess? That's where clinical documentation integrity specialists step in. These right here are the exact documentation gaps that basically force a CDI specialist to formally query the clinician. If a doctor just writes CHF, well, that's ambiguous. Coders can't just guess. Is it acute? Is it chronic? Systolic?
Because acute on-chronic systolic CHF is an MCC, while plain old CHF definitely isn't. Or what if you have conflicting notes? Like, one doctor says pneumonia, but a specialist note calls it atelectasis. A CDI specialist has to jump in, clear up the ambiguity, and get a highly specific, codable diagnosis into the permanent record.
And this perfectly illustrates how we actually have to ask those questions legally. On the left side, you've got a leading query. Based on the high lactate, do you agree the patient has septic shock? Guys, that is a huge compliance violation. You can never, ever use leading language just to go fishing for a higher-paying DRG. Now on the right, that's the correct way. You state the clinical evidence, the lactate of 4.0, and then provide a multiple-choice list of non-leading options, and you always include an option for other or clinically undetermined. It all boils down to this golden rule of compliance. Queries must not suggest a diagnosis or provide clinical information that the clinician didn't document themselves. They have to be auditable and strictly evidence-based. Because if Medicare audits your hospital, they're going to scrutinize every single query. If it even looks like you're coaching doctors to write down high-paying buzzwords, you are looking at devastating fines for unethical upcoding. Okay, part 5, real-world coding scenarios. Let's take these strict rules and apply them to one of the most highly scrutinized clinical conditions we see, sepsis. Sepsis is never just a single code. It's an entire timeline of escalating severity, and it requires really strict step-by-step sequencing. First, you have to identify the localized infection, like an E. coli UTI. Then, if that bacteria hits the bloodstream and triggers a systemic response, you've got sepsis. If that sepsis then causes an organ to fail, say an acute kidney injury, boom, you now have severe sepsis. And if their blood pressure completely bottoms out and they go into circulatory failure, that is septic shock. Every single one of these steps requires incredibly specific documentation. I really need you to burn this golden rule into your memory. Do not code a severe sepsis unless the provider explicitly links the infection to the organ dysfunction. Seriously, if the chart says sepsis on page 1 and then mentions acute kidney injury on page 5, but never actually says the kidney injury is due to the sepsis, you absolutely cannot code severe sepsis. Missing that clinical linkage is honestly one of the most common reasons auditors downgrade MSDRGs and claw back money. Finally, part 6, denial prevention and wrap-up. So how do we actually stop these auditors at the gates and protect our hard-earned revenue? By catching the errors before the claim ever leaves the building. Here are the proactive strategies every revenue cycle management professional really needs to implement. You've got to have rigorous pre-bill checks using clearinghouse validations to make sure your POAs and MCCs actually make sense. You also need proactive CDI partnerships. Do not wait for denial to clarify a messy note. Query concurrently while that patient is still in the bed. You've got to do periodic internal audits on your complex charts. And maybe most importantly, track your denial patterns. If a specific surgeon is constantly forgetting to document their surgical approach, you take that data and you educate them. I'll leave you with this to think about. If just one missing word linking an infection to an organ failure can trigger a devastating audit and a massive loss in reimbursement, is your hospital's documentation truly telling the full, accurate clinical story of your patients? Precision is quite literally everything in this industry. If you're enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Keep studying, keep querying compliantly, and I'll catch you in the next explainer.